Hello everyone, my name is Roisin Buckels. I'm an orthoptist and a lecturer in the United Kingdom, and today we're going to be talking about how we measure vision in children. So let's look at what we're going to cover in this lecture. So we're going to first look at visual development of children, how their vision develops from birth through childhood. Then we're going to look at relevant history that you gather from the family of the child you're testing. And finally, we're going to look at the different vision assessments depending on the age of the child. So let's start with visual development then. It's really important to stress that the vision of a child at birth is very poor. You can see here the newborn picture. It's roughly the equivalent to about 160 in terms of Snellen vision. It's really blurry and vision develops throughout that early period in childhood. So when you're assessing a child, you need to know how old they are and what is normal for that age so that you can say if the child is reaching where they should in terms of their vision or if they're behind. So by 6 to 8 weeks, a child should be able to do what we call fixing. And fixing is where you show something to a child, usually a brightly coloured large toy or a light, and the child will look at it steadily. That is fixing. They may also do it to the faces of relatives nearer the 8-week or 2-month mark. By 2 to 3 months, not only are they fixing on the object, but if you move that object, the eyes are able to follow it. So this is called fixing and following. And by 3 months old, a child should be able to do that. From 3 to 6 months, there's a massive jump in vision. Vision matures a lot in that time. So you go from just being able to look at things and follow them to being able to see things in more detail. So you can see by the 7-month mark, there's quite a lot of clarity in vision, but it's still mainly focused on the near distances. The distance, kind of 2 meters and beyond, is still quite blurred. So their vision will be better at near, but still blurred for the distance. Then by 12 months, that's cleared in the distance. You see in this picture, we can pick out things in the foreground and in the background. And by 18 months, vision is coming up to around 6'9", between 6'9" and 6'12". By 2 to 3 years old, they should be getting 6'9" or 6'6". And by 4 years old, you then have an adult level of vision. It's really important to note that if a child is born prematurely, they will be further behind this chart. So for example, if a baby is born 3 months early, by the time they are 9 months old, they will only be seeing equivalent to a 6-month baby that's been born at full time. The best way to understand this is to practice. So if you have young children in your family and in your communities, practice on them as much as possible. Learn what is normal. Because once you know what is normal, okay, I know that my niece and my daughter were able to see this at 3 months old, you can start to pick up where the issues are. So practice, practice, practice on as many children as you can. Moving on to the relevant history. This is important because if you were assessing an adult, they would come in and they would tell you what their vision problem was. And a child is obviously not able to do that. You may only see the child for 2 minutes, maybe less during your assessment, and that family is with that child all the time. So you're going to ask them, what are you concerned about? What have you noticed? And it can help guide you in your assessment. They may say something like, I'm concerned they don't see things down on the floor. I'm concerned that one of their eyes turns out to the side. And you may not notice it in clinic, but it might be enough to make a referral for that child. In terms of their general health and development, this is so important because if there are any concerns about the child's general health, it is going to impact the development of their vision. So, for example, how is the child's development generally? Are they suspected of having a syndrome, for example, Down syndrome, which will impact their vision? Similarly with birth history. If a baby is born early, we've already discussed this. Also traumatic births. So if the baby that needed forceps to deliver the baby, was there any damage around the eyes? Was there any bruising when the child was born? Equally, was there any issue with the child not having oxygen at birth? So what we call hypoxia. When babies are born with the umbilical cord wrapped around their neck, they sometimes don't get enough oxygen at birth, and that impacts brain development, which impacts vision. Family history. So many eye conditions run in the family. If one of the parents has worn glasses since they were 4, if one of the parents has always been known to have poor vision, that's really important to know. So let's look at the different kinds of vision assessment that we have then. For the purpose of this lecture, I've split vision assessment into 3 categories. How do we assess vision in babies, so up to 18 months? How do we assess vision in our toddlers, which is 18 months to 3 years? And then 3 years and upwards. So when we're assessing vision in babies, there are 2 types of assessment that we can do. One of them, visual acuity, is the picture on the right. So this is a very specialised test that has been designed for assessing vision in babies. Not every clinic has these tests, so I'm also going to discuss the other kind of assessment that we do, which is visual behaviour. And this is more looking at how the child is behaving and assessing whether it's normal. So let's look at both. So in terms of visual behaviour, it is exactly what it sounds like. Is the child behaving in a way that you expect? Which is why it's so important to know what to expect at the different ages and really understand that. So a couple of easy things you can assess. When you come into the room, does the child look at you? It sounds obvious, but if they look at you, they have seen you come into the room. Do they make eye contact? So children with better vision will usually make eye contact. Some children don't make eye contact, and that's fine, but it's a really good sign of are they able to hold your gaze steadily? Do they mimic your facial expressions? So children from about 3 months old will start copying what they see. So if you smile at the child, they will often giggle and smile back. If you frown at the child, they will often pull away. It's important to do these kind of things without too much sound, because what you want to know is, do they respond visually? If you pick up a toy, any kind of toy, brightly coloured, anything, do they look at it and do they reach for it? So most children of a certain age, if they see something they want, they will reach for it. In order to do that, they have to have seen it, they have to have good enough vision, and they have to have developed hand-eye coordination. So it's a good sign of them reaching for the toy. We talked before about fixing and following, and that is the ability, as we said, to look at something and follow it as it moves. And you can check that with smaller toys and lights and with larger toys and lights. And is the behavior different? Are they happy following the larger? Do they not follow the smaller? You can see that gives you an idea of how good their vision is. Really important to have at least some silent toys in your kit. So if you're regularly assessing children, if you can access a few colourful toys, it will make a huge difference to your ability to assess children. Something with lights is really, really useful, and you want it to be silent, as I said, because children who have poor vision but normal hearing will locate things with their hearing. So you want to have something that's beautiful, bright colours, but silent to be able to tell whether they are actually following it without using their hearing. In children, it's equally important to check both eyes as it is in an adult. If you saw an adult in clinic and you saw them in a centre, you would make sure that you checked both eyes, and so you must do it with children as well. The thing is that if a children has poor vision in only one eye, you won't notice it unless you cover each eye. And equally, if they have poor vision generally, it will often be worse in one eye. That's really important to note on your referral or in your clinic notes. The thing is that with young babies, they often pull away. So if you go to cover their eye, they're going to lean backwards. What you're looking for is that reaction the same when you cover the right eye and when you cover the left eye? If the child is quite happy having their right eye covered, but they get really upset when you cover their left eye, it implies that there's a difference in the vision. So if they get upset when you cover one eye, maybe that is the good eye and they don't like you covering it. So even if the child cries when you cover either eye, is the reaction the same? This is an example of a child who did not have normal visual behaviour. So this test involves putting something down on a table or on the floor and seeing if the child can find it. So in this example, it was grains of rice and it was put on paper on the table. When you're giving the child something, if it's small, you want to make sure that it's edible. You don't want the child picking up something and putting it in its mouth if it's not edible. So rice or raisins, anything like that. So can you see that this child, when it's trying to find the rice on the paper, he puts his hand flat and he pats the paper until he finds where the rice is, and then he pinches it. That is not normal visual behaviour. Usually, a child does not need to touch the surface in order to find what they're looking for. So this is a child who had poor vision in both eyes. You can make this test easier or harder. You can put, say if you were using white rice, you could put that on a dark background and see how they behave, and then compare it to a light background and see how they behave. So let's move on to how we test visual acuity in these young children. So the difference with visual acuity is that it gives you a score. So the same as an adult Snellen equivalent, 6-6, 6-12, 6-18, whereas visual behaviour is very subjective language. So with visual acuity, these are some of the tests that we have to test their vision more accurately. And I'm going to show you some videos of this. All right, so the first vision test for babies that I'm going to show you is the preferential looking test. And I'll play a video of this in a moment, but the principle of this test is if you show a card to a baby at quite a close distance and there is a pattern on that card, if the baby can see it, they will look at it. So the test allows you to make smaller and smaller gratings so the pattern gets more difficult to see and you're looking to see if the child still looks towards it. So let's play the video here.
Teller acuity cards are being used to estimate the grading visual acuity of this baby. The test uses the forced choice preferential looking technique, which is based on the principle that if you present a display to a baby, half of which is quite plain and the other half has some pattern to it, the baby will tend to look at the pattern.
So can you see that sometimes the baby wasn't interested, but when they were interested, they were looking towards the pattern consistently? Another thing to note is that, did you see at the beginning when they put the eye patch on the baby was not happy? That's a normal reaction. Babies don't like things kind of touching their face unexpectedly. But once you put the patch on, you distract the baby with a toy in a game and then move on to the test. So the next test that I'm going to show you is the Cardiff cards test. So again, I'm going to play you the video and then we will discuss it.
The Cardiff Cards Visual Acuity Test uses familiar pictures and a procedure in the form of a game to attract and keep the attention of young children. The test relies on the technique of preferential looking. That is, the observer simply notes the child's eye movements to determine whether he or she can see the picture. Older children may point to the picture.
So do you see there that the Cardiff card test is useful for young children, but useful for those that are a little bit older because it uses pictures. So the child can either point to the picture where they see it, they can say the name of the picture, or they can just look towards it. So the pictures get harder and harder to see, and there are 3 sets of the same picture. So if you get to a point where you're not sure if they've seen it or not, you can check it with the other ones. And again, as with all of our vision tests in children, we're going to try and do it each eye, and we're going to see if there's a difference in their response. So a couple of tips for babies then. These seem obvious, but they're worth saying. The easiest way to examine a baby is if they are fairly content. So if they're not too tired, they've not just been woken up for the test, they've been fed recently and they have a clean nappy. If you have a child that's in pain, say they've had an injury to the eye, they will be more difficult to assess. So for those children, you can't always win them round when they're younger. Something else to bear in mind is that the most stimulating target is usually your face. So even if you have limited equipment on the day, actually looking at the baby, smiling at the baby, moving around, and you'll see whether the baby is responding normally to you. With children, you do have to be quite adaptable. So children tend to behave better if you are on the same eye level as them. So if they can sit on the parent's knee, or if you have a chair that goes down, it will help them engage in your assessment. Also, if the child starts crying, and a lot of children do when they're coming for an appointment the first time or the next time, if you shout, it usually means that the child gets more and more distressed. The best way to calm children down in clinic usually is to talk in a very quiet, low voice. Don't rush, talk quietly, and usually that will calm the child down. Whereas if you get louder, they get louder, so it becomes a bit of a battle. This child in the top picture has been swaddled. That's really useful if you need to examine the eye, but babies, when they're swaddled, tend to either go to sleep or get quite upset. So it's not so good for testing the vision, but you can do it if you need to. So now we're going to move on to our toddler children. So these are children that are a little bit older. You may find that if they're only just 18 months old, you're using the same tests as before. You don't have to use different tests for once they turn 18 months. It just depends on the child. But when you're 18 months old and older, your vision has improved in the distance. So you can now see more clearly in the distance. And so our tests are going to be either at near or at a normal testing distance of 3 or 6 meters, the same as we use for adults. With babies, they may be able to see okay in the distance, but they're not particularly interested. They're generally only interested in what is happening right around them, which is why the tests are so much closer. So with these slightly older children, you can test them at near or you can test them at distance. And the tests that we use are more like the tests that we use in adults. So you can see here, there's a test here called K-Pictures, and I'll show you a video of that in a moment. K-Pictures is really useful because it's pictures that children recognize generally, and it's not as intimidating as a letter test. You can also use matching. So this is really useful, and the next video shows this. In children who are a little bit shy and aren't sure, the matching card is really helpful because it helps the test be more of a game, and the child doesn't need to talk to you for you to test their vision. So let's see an example of this in the next video.
K-pictures are being used to assess the visual acuity of this child. This test can be used from about 2 years of age. It uses familiar pictures which a child either names or points to on the matching card.
So can you see there how the fact that they had the matching card enabled that child to engage much better with the testing? So I would really recommend that any test that you have for assessing vision in these slightly older children, you have a card with the answers on it so that they can point them as you go along. So for the final category, let's look at how we're assessing children in these children who are slightly older for their vision. So this is going more towards our standard adult tests. So they're going to be very similar. So this first picture here is Sonksen Logmar letters. So it's the letter test, excuse me. This one here, the one in the middle, is the Lear symbols that is very commonly used. And this one here is the tumbling E, and it's either on a screen, in a book, or this one's being used on the phone here. All of these are appropriate tests. If you have a child that is more shy, you can still use the Ks from the previous video. So just having options depending on how engaged and how mature the child is. A couple of tips for assessing children who are older than babies, so are kind of 18-month to 5-month-old. If you make it a game, they are much more likely to engage with you. So whereas with an adult, you will ask them to cover one eye and read the letters, with a child, you're going to make it more exciting and you're going to encourage them and congratulate them when they get it right. So if a child gets the picture and they've tried really hard, you're going to tell them well done, just to make them feel more comfortable and feel better. A relaxed environment. If you do have the option of a quieter room where you're assessing or in clinic, it will really, really help. Because if you're testing a child in the waiting room or you're testing where there are lots of other people, the child will get quite distracted during the testing. So if you can secure the quieter room when you're assessing children, that will be much easier for you. Smile and reassure the child, which we've already said. Try not to raise your voice and shout at the child. It usually means that you won't get much more of an assessment done. This bottom picture, the whole family is getting involved. This is really helpful in the children who are quite shy. So a bit like the matching card, they might not want to do the test for you, but as soon as their older brother or sister starts doing the test, they will want to do it. So when you have the family, they're encouraging the child to do the test. Make sure they are not saying the answers though, because you want to check the vision of the child. Adaptable test technique we've already talked about, that you may need to be kneeling on the floor to get to the eye level. You may need to move around a little bit to keep their attention. Toys, again, we've discussed how useful these are, and you want a combination of toys that are silent and toys that are a little bit more noisy. So here's a few examples of toys here. Glove balloons are really useful in clinics, as a reward for a patient for doing well, or to test the vision. Do they follow it? Do they follow it with both eyes? And stickers. Children, if they think they're going to get a sticker at the end of the testing, will be much more engaged and try much harder, so it does make a difference. All right, so that is the end of this lecture. I hope it's been helpful, and thank you very much for your time.